Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs in the transition to value-based care. My name is Hadley Taylor, a MIPS Quality Program Consultant. I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hello, Dr. Mingle.
Good morning, Hadley, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
Wonderful. Quick reminder before we begin, you can always send us your questions for Dr. Mingle on LinkedIn, YouTube, or via email at hello@minglehealth.com. Let's dive in. Our first question today comes from Mary Ellen. Mary Ellen asks, the MIPS final feedback scores have been released for the 2022 performance year. What do we know so far?
Thanks for the heads up, Mary Ellen. On or about August the 10th, 2023, Medicare released MIPS results for the 2022 performance year, which will determine MIPS adjustments for the 2024 payment year. Scores are initially released only for the review by the provider and groups to which or whom they pertain. It's important to review your scores and request targeted review if you believe there's an error. You can access your scores on the website qpp.cms.gov. You'll need to sign in with your QPP credentials. If you don't have credentials, you'll be directed to the HARP system, that's HARP, to prove your identity and to create an account. Once you have access to your scores, you'll have access to an electronic form to request a targeted review. Targeted review must be requested before 8 p.m. Eastern Time, October 9th, 2023. The adjustments earned with your 2022 MIPS submissions will show up in Medicare Part B payments for your 2024 services. We expect scores to be released to the public in March of 2024. We expect the 2022 QPP Experience Report to be published by Medicare in June of 2024. What we do know so far is that a perfect composite score of 100 is queued to earn an 8.25% positive payment adjustment. This is astounding. The highest MIPS positive payment adjustment we've previously seen was 2.34%, seen for the 2021 performance year. It breaks down for 2022 to 2.23% on the core revenue-neutral MIPS program, with another 6.01% going to the top performers with an exceptional performance bonus. These scores prompt two additional questions. Why such a big jump? And what can we expect in future years? First thing to note is that 2/3 of this highest positive adjustment represents the exceptional performance bonus. Medicare has invested $500 million every year into the exceptional performance bonus for the first 6 years of MIPS. The 2022 performance year was the 6th year. The exceptional performance bonus has sunset. This bonus will pay out in the 2024 payment year, then we don't expect to see it again. The second thing to note is that this top-tier exceptional performance bonus is a lot higher than what we have seen before. It's the same $500 million of previous years, so it has to be distributed between significantly fewer exceptional performers. At this point, I think that relates to two factors. The exceptional performance threshold was 85 for the 2021 performance year and went up to 89 for the 2022 performance year. A higher score was required to share in the bounty. Fewer providers and groups qualified, more money goes to each of the winners. Second, the cost performance category. We last heard from the cost performance category in the 2019 performance year. It was worth 15% of the total composite score. It was not scored in 2020 or 2021 because of the pandemic. For 2022, it was back at 30% now of the total score. Cost is the only category that is scored on a true percentile basis. The other three categories all have scores that cluster near the upper end of the range. Costs will have forced scores down on the average, driving far more providers and groups below the exceptional performance threshold than would be explained by just the increase in exceptional performance threshold from 85 to 89. All right, so what can we expect in future years? The 2022 performance year was the last year of the exceptional performance bonus. That will result in a big drop in the highest possible positive adjustment for 2023 and years beyond. On the other hand, there are other dynamics that are going to continue to push the maximum possible positive adjustment up. The performance threshold is proposed to be set at the average scores earned in the performance years 2017 through 2020. Those averages were set in years with bonuses that are now gone, specifically the end-to-end electronic reporting bonus and the high priority measures bonus. And it's set without cost factoring in that is now scored at its maximum weight. Performance threshold was 60 in 2021. It went to 75 for 2022 and 23, and it's proposed to go up to 82 for 2024. That's likely to bring the number of winners down significantly. Now, cost is not going away. Scores for cost should average 15. That's half the maximum possible 30 points. You should expect cost to be the lowest scoring category on the average. Finally, the pandemic is officially over. With its end, we can expect COVID forgiveness to either suddenly or progressively end. Now, with more groups having to participate, average scores coming down, performance threshold going up, there will be far more practices with negative adjustments. A smaller set of practice earning positive adjustments will share in the larger amount of that Medicare retains. So it proves to be to be heating up for a much more competitive future in the MIPS program.
Great. Thank you so much for that information. There's a lot to think about there. Let's move on to our next question, which comes from Tom. Tom would like to know, what do you, Dr. Mingle, think about the QDC codes for our APM Performance Pathway, APP, quality reporting? We are a disseminated network. Our participating providers provide services across a wide geography using electronic health records that we do not control.
Great question, Tom. For everyone else, let me explain QDC codes. QDC stands for Quality Data Code. They are essentially fake CPT codes Medicare invented when they first introduced quality reporting. They were designed to be added to Medicare claims to report to Medicare quality performance on that specific patient at that specific visit by that specific provider. They are codes that are designed to be part of the claim, but not to result in payment, but only to be collected by Medicare to accumulate and calculate on an annual performance score. Every measure has at least two QDC codes. One code means performance is met. The second code means performance is not met. Other codes are used as needed for other concepts like exclusions, measure stratifications, or to give more clinical nuances to each report. QDC codes were the foundation of claims reporting. Now, claims reporting has a number of weaknesses and has been slowly disappearing. Although all measures, even new measures, are still created and published with QDC codes in the specifications, even when those new measures are not eligible for claims reporting. Now, normally, I prefer my practices to migrate to digital reporting and steer clear of QDC codes. Your need, however, is really the one place where I think QDC codes shine. When you don't have control over the EHR, essentially, when you don't have the clout to assure that your needs for data extracts from the EHR will be honored and accurate. QDC codes are a great way to keep control of your quality reporting and deliver winning scores to Medicare. There are a lot of great billing systems that recognize when patient demographics, build CPT and ICD codes, indicate a specific quality measure is indicated. Those systems prompt the billing provider to select the appropriate QDC codes. If you're doing quality reporting using the claims mechanism, you'd need those codes to go to Medicare. But a good registry like Mingle can recover the QDC codes from your billing system and build a MIPS CQM submission around them. And unlike claims reporting, we can supplement the QDC generated numbers with data from year end manual chart abstractions to fill in holes you might have missed in the initial code selections made at the time of service. Now, long term, I still like digital reporting and think you should be looking ahead to a time when you maintain your own patient database that is fed by automated data exchange each time you see a patient and document care in somebody else's EHR. It will give you the desired digital measurement capabilities and support the promoting interoperability data exchange measure requirements. But you don't have control of the local EHR, and it may be decades until you can rely on the flow of data from each system. In the meantime, with QDC codes, you and your providers have control and can generate accurate and winning performance measures.
I will admit, I love it when I see a QDC code come across. I'm like, yay, that's great to see. I know it's not as good as electronic, but I still love it. On to our next question. Today, Mary Ann would like to know, I'm trying to get a handle on the PDMP measure, the Prescription Drug Monitoring Program measure, in the Promoting Interoperability MIPS Performance category. I understand the measure now applies to Schedule 3 and 4 drugs, not just Schedule 2. It seems a monumental task for my providers to comply with all the Schedule 2, 3, and 4 drugs. Where can I even find a list of the Schedule 3 and 4 drugs?
Great question, Marianne. First, relax, take a couple deep breaths. This isn't as hard as it seems. The measure requires an attestation. It's yes or no for at least one class 2, 3, or 4 drug electronically prescribed for at least one patient during the performance period. The provider, any one or more of your providers, conducted a query of the applicable PDMP system for prescription drug history. Now, you don't have to have an electronic integration with the PDMP system. It does not have to be with every prescription. The expansion to class 3 and 4 drugs gives you more opportunities to comply. It does not represent a larger compliance requirement. As to a list of drugs by schedule, the gold standard is the list that the DEA publishes and can be found on their website. The DEA, of course, is the Drug Enforcement Administration, and you're interested in their diversion control division. When you're on the DEA diversion control division site, you'll be looking for a controlled substances schedule. Specifically a CSA schedule. It gives a list of drugs by schedule. Within each schedule, there'll be an alphabetical list of substance or generic names with an attached list of available brand names. You can skip the first 10 pages of Schedule 1 drugs that are not legally prescribable. Thanks a lot, Marianne, for a great question.
Our final question today comes from Corinne. Corinne would like to know, what would you recommend for MIPS measures for the easiest, best, most efficient measures for an ophthalmologist?
Great question, Corinne. And a difficult one. Ophthalmology, I think, is one of the more challenging specialties to deal with. There's not yet an ophthalmology MIPS value pathway, so you can't go in that direction. Now, there is an ophthalmology specialty measure set. A typical advantage of a specialty measure set is that if you do them all, or all that apply to you, you get full credit, even if you don't have 6 measures. But there are 15 measures in the ophthalmology measure set, including a couple that apply broadly, but could be an awkward fit. First, there's 5 general measures that theoretically apply to any provider, or nearly any provider, but could be an awkward fit in ophthalmology. It's measures 130, documentation of current medications in the medical record; 138, tobacco use screening and intervention; 238, use of high-risk medications in older adults; 374, closing the referral loop, that is receipt of a specialist report, and measure 487, screening for social drivers of health. I think these all generally fit in most specialties, and they can fit in ophthalmology. But as a referring primary care physician, I don't think I'd be looking at these specifically if I were judging the quality of the doctor to which I was referring my patients. There's a single measure about macular degeneration, that is number 14, dilated macular exam. There are two diabetic eye measures, one diabetic retinopathy, communication with a diabetic provider, and 117 diabetic eye exam. There's one open angle glaucoma measure, number 141 intraocular pressure. There's 4 cataract measures. That is 191 visual acuity 90 days post-op, 303 functional improvement 90 days post-op. Now measure 304 patient satisfaction 90 days post-op. And number 389, the difference between planned and final refraction. There are 2 retinal detachment measures. Number 384, no return to the OR within 90 days. 385, visual acuity improved in 90 days. There's also a couple of EMA clusters. That's EMA, EMA, which is eligible measure applicability. Medicare looks at these measures, and if you submit any one of them, they expect you to be able to submit all the others in the cluster. So if you submit one cataract measure, you should submit all 4. If you submit any one of the 3 internal eye care measures, they expect you to submit all 3. Those 3 internal eye care measures are the 2 retinal detachment and repair measures, and the open angle glaucoma measure. There are 2 Part B claims measures, number 141, the open angle glaucoma measure, and number 226, the tobacco use measure. So if you're a small practice, that is 15 or fewer providers, you're eligible to use Part B claims, and you could do those 2 measures for a complete submission. Now, the American Academy of Ophthalmology also operates a QCDR called the IRIS Registry, and they have 26 measures. Now, Medicare doesn't require to use the QCDR. If you can find a 6-measure set or a smaller set that you can justify through one of these rules, that is fine. That is good. Now, if you are if you're a solo practitioner or in a small practice, if you're 15, you can use the Part B claims method, or perhaps the cataract set or the internal eye measure set. But if you're in a large group, and I know in large groups, there's often compartmentalization of the various eye problems. One person doing cataracts, another doing retinas, another caring for the diabetic eyes. So together, you can choose the 6 best measures and put in a group submission. I think it's particularly hard as a practitioner in a group practice to individually submit 6 measures. You'll run into some rules that'll limit your choices. We're happy to help. One thing you'll want to do as you're going through this is have an expert in your pocket to help do the eligibility screening, to help you justify to Medicare when you don't have enough patients to report any of these measures. If you get a first pass denial of your submission, you may need to put in a targeted review request after the scores are released. And again, proving that you have not enough patients for some of the measures, or that they don't apply to your practice, are going to be critical to having a winning submission. Thanks, Corinne, for that great question.
Thank you, Dr. Mingle. And thanks to Mary Ellen, Tom, Mary Ann, and Corinne for all of your great questions. Please keep sending them. We really like to help you and help ourselves learn MIPS better. And as always, thank you, Dr. Mingle, for sharing your insights and your pearls of wisdom with us today.
Thank you, Hadley, and thanks to all of you for the great questions. I want to be helpful, and I want to make this useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.